So diffuse large B-cell lymphoma is the most common subtype of lymphoma, non-Hodgkin lymphoma, that we see in adults in the US. It's about 35% of cases. And it's a fast-growing subtype of non-Hodgkin lymphoma, and the name comes from the way the cells look under the microscope. They're sort of spread out and they're large B cells. So diffuse large B-cell lymphoma can present really anywhere in the body. Probably most typically, people will develop enlarged lymph nodes, so the symptoms relate to where the lymph nodes are located. They could be anywhere in the body. You could have a lymph node in the neck, you could have lymph nodes in the abdomen. Sometimes patients will have fevers, drenching night sweats, or unexplained weight loss as symptoms. That usually reflects a fair burden or a lot of diffuse large B-cell lymphoma. It can present in unusual sites, like in the breast or in the brain or in the skin. So it really can present in many different ways. So you need a biopsy. The biopsy is really critical. We have pathologists who look under the microscope. They look at what do the individual cells look like, what is the pattern or architecture of the piece of tissue they're looking at, and then they do stains to highlight proteins on and in the tumor cells. Sometimes they do some very fancy cells, molecular tests, and then they come back to us with a diagnosis. We need enough tissue. A fine needle aspirate or a very tiny pieces of tissue is not enough. We really need that. What does the group of cells look like? So generally we get a core needle biopsy or what we would call an incisional or excisional surgery-based biopsy. For many years, since the early 2000s, we've been treating patients pretty much exclusively with R-CHOP chemotherapy, a 5-drug combination that's generally quite well tolerated. More recently, we know in patients who have higher risk disease, so they have a couple of risk factors on this scale that we look at when we have a newly diagnosed patient. We know that those patients may benefit from replacing the O drug or vincristine with a drug called polatuzumab. So polatuzumab, our CHIP chemotherapy, has become another standard of care in patients with a little bit higher risk disease. So I think just asking, well, what happens if my disease doesn't go into complete remission at the end of treatment and there's still something there on the PET scan? Or what happens if my disease comes back early? We sort of divide relapses currently into, does it happen within the first year of completing treatment or is it after that? Because the treatment options are quite different depending on that. And I think just having a conversation at the time when you start initial therapy can be very helpful because, of course, it's going to be very anxiety-provoking to have residual disease at the end of treatment or to relapse, but to know, oh, I know there are some very good treatment options that are available for someone like me. So for patients who don't go into remission with initial therapy or relapse within the first year, typically we would think about CAR T-cell therapy. There are some newer CAR Ts and other what we call bispecific antibodies and things in clinical trials now, but currently CAR T. For patients who relapse after the 1-year mark and are sensitive to additional chemotherapy, and are younger, probably under 70 to 75 and otherwise in good shape, those patients tend to go to what we call high-dose chemotherapy autologous stem cell transplant, though we will use CAR T in patients who aren't eligible for that or who do not achieve a complete remission with the next line of chemotherapy. So there's a lot of CAR T, and in some situations we'll do stem cell transplant. Yes, there are a lot of new treatment options, including, CAR T now we've had for 7 or 8 years, so that's becoming a more standard therapy. But there are newer CAR T-cell products combining what we call bispecific antibodies. These bind to the tumor cells and your own immune cells to bring them together and cause destruction of the tumor cells. These are being studied in combination. We have some new what we call antibody drug conjugates. These are drugs that bind to the surface of the tumor cell and deliver a chemotherapy drug directly into the cancer cell. These are looking very promising. We have some approved agents already. So it's really a lot of really exciting work going on in this disease, and I think we're seeing more and more of our patients have durable remissions, which is obviously what we hope for.